Let's get this started. So good morning, everybody. I'm Mart Sabunju. I'm stepping in for Seb this morning. I'm just going to make a very short announcement. As Seb said yesterday, we had a sort of a little bit of an issue with the posters. Overnight, we worked really hard to move things around. So the posters have been moved around. They have the same tags, but if you're presenting your poster, it's not where you hung it. Most likely it's moved to another location, but it will have the same tag, and you can easily find it because they've been ordered in a different way. And related to that, all the poster tubes are actually at the front desks now in that room. So you're going to have to go and find your poster tube there because they were all over the place. So for the speakers who are going to talk this morning, I just want to remind them that for the slides, they're going to have to press the green button, this giant round green button, to go forward, and the red button to go backward. With that, we have an amazing lineup this morning, and I'll just hand over to Lena and Pierre.
Good morning, everyone. Welcome to our session, Computer-Assisted Intervention, Computer-Aided Interventions, actually. I'm Lena Meyer-Hein from the German Cancer Research Center.
Calimera, I'm Pierre Janin from INSERM and University of Rennes in France.
We're looking forward to 6 exciting talks.
So definitely I think this paper are good examples of how computer-assisted intervention is quite complex and diverse, and why we need to develop dedicated methods to deal with this specific kind of data, which are surgical data. So we will start with Rachel Sparks, that will present her work on automatic trajectory planning for depth electrode in epilepsy surgery. Please, Rachel.
Hi, thank you for having me. And I'll be talking about automated trajectory planning. The reason why we want to do automated trajectory planning is that epilepsy affects nearly 7 million people, 30% of whom are drug resistant. And resection can be curative if we can identify the epileptogenic zone. In order to do this, we typically take a lot of preoperative imaging, and if we can identify the lesion directly, we can go straight to resection. However, in about 75% of cases, this is not the case. In that case, we place SEEG electrodes in the brain at the epileptic zone using surgery, and then we record electrical signals from the brain to define where the EZ is, and then we can move on to resection. This talk is focusing really on the first 2 parts of this procedure. And the reason why we're focusing on this is planning these trajectories is actually very complicated. We typically place between 6 to 12 electrodes, and we start by having a very general idea of which regions of the brain we want to go to. And from this, we have to define trajectories that attain these targets and avoid blood vessels. And we have to assess each trajectory for having a surgically feasible entry angle, as well as safety to avoid blood vessels, and that the electrode is placed in gray matter to record the brain signals. And surgeons typically have to scroll along the trajectory to do these plans. And finally, the plan also must provide good 3D coverage of the region we want to target. This can take up to 4 hours per patient to do one of these plans. And so we think automated planning can really help speed up the process. There's some previous work in automated planning. However, it requires the user to specify a target point or manual region of interest, or it's constrained to very few sample targets. And then the second step is to optimize these trajectories by risk. And the limitations, as I said, is we rely on the user to identify the best target or region, so it actually takes quite a while to define this. And also, sampling these targets typically ignores vessel anatomy at the target area, so many of the trajectories we're optimizing are high risk. And here's an example of a hippocampus segmentation where you can see there's several blood vessels, so ignoring this information doesn't make sense. So the novel contributions of this work are, first, we defined a user interface so there's a very intuitive selection of regions of interest. The user can essentially go and navigate through the screen and select labels from a brain parcellation to define the regions that they want to target. And we also allow the user to select superficial regions of interest on the brain surface that they want the trajectory to go to further constrain the task. And as you can see from the video, the user can scroll through the image, find the regions of interest that they want to target, and it's actually very quick and intuitive. And like I said, they can target superficial regions. And this is essentially, now they've done a plan, they've placed 8 electrodes in the time I've been talking. Once we have this information, the algorithm then performs a real-time 3-stage optimization procedure where we first determine suitable target points in each region of interest. We then determine suitable trajectories, which are target points in the region and entry points on the skull surface. And finally, we compute the combination of trajectories for all the regions of interest. In order to do this, we need to do some data preparation. So we have the regions of interest, gray matter, and sulci we obtain from a T1 weighted MRI. We obtain critical structures from a variety of scans, and we obtain potential entry points from a CT. And here's just a quick video showing you all the data together. As you can see, this is actually a really complex data set with many objects that are quite large. And we want to evaluate the relationship to target points and trajectories. In order to do this, we use a bounding volume hierarchy, where we essentially represent each object as triangular meshes. We construct a binary tree by partitioning the data set. You can sort of see this toy example here. And then it makes it very quick to perform a search, where we can essentially navigate through the tree, finding the closest element. And this allows us to perform distance and collision detection with each object. We use this information to perform a target point selection. And the way we do this is we calculate 2 measures. One is a measure of the distance from the surface of the object, because we want to place these trajectories within the middle of the object. And we also use it to calculate a distance from blood vessels that we wish to avoid. And then we create a summed measure, and this gives us our risk score for the trajectory points. We then determine candidate target points by computing the local minimum of the object. As you can see here, we're using hippocampus as an example. And then we select a very small set of the minima with the lowest risk score to obtain our candidate target points. Once we have our candidate target points, we can perform trajectory selection, also with the bounding volume hierarchy, where for each trajectory, we reject them if there's a length or angle criteria that are not met, or if they don't intersect the superficial region of interest. And you can see at this point, we have a very limited number of target entry points that we're considering. Then we also reject if it's too close to a critical structure. And finally, for the remaining trajectories, we compute a risk score that quantifies their proximity to blood vessels. And we do this for each electrode we wish to place. Once we have this, we can find the combination of trajectories. And we want to do this to provide a good spatial coverage. So we not only minimize the risk score for each trajectory, but we also impose a distance criteria. So without the distance criteria, what you can see is that there are several electrodes that actually physically intersect. So we need the distance criteria to find trajectories that are surgically able to be placed apart from each other. And here's an example of the planned computation in real time. So first we allow the viewer to manipulate the scene, so you can see each region of interest that you're going to target. We add blood vessels as critical structures, and the skull as an entry point. And then in this instance, we're selecting some options, so we're also avoiding sulci and improving gray matter capture. And what the algorithm is doing right now is going through each region of interest, finding those candidate target points, then the candidate trajectories, and then optimizing the combination. And what you'll see shortly is that once it's done, we display the trajectories to the user to evaluate. And this entire process typically takes between 1 to 5 minutes. You can see in this case it's already done computing, and the user can go and navigate the scene and assess the trajectories to ensure that they're safely away from blood vessels and that they're attaining the targets we wish to hit. For our experimental design, we analyzed this algorithm on 20 patients with a total of 186 electrodes, and we compared our method and manual planning. And we looked at 3 things. We looked at the time to compute a plan, quantitative measures of risk, angle, and gray matter capture for each electrode, and finally we did a qualitative evaluation where we looked at the 3D spatial arrangement of the electrodes. And what you can see for the computational efficiency is we assumed it's roughly 15 minutes per electrode for manual planning. And so what happens is the manual plan takes somewhere between 100 to 200 minutes. Our plan takes somewhere between 15 to 279 seconds, or roughly 1 to 5 minutes. And manual planning takes between 1 to 3 hours, depending on the number of electrodes. So we're orders of magnitude faster. However, the speed doesn't really matter if the trajectories we're getting aren't good, so how do we do on the other measures we're looking at? For the trajectory evaluation, we have much lower risk score, which is not that surprising since that's our optimization criteria. We also have a lower entry angle with the skull, and we also have slightly higher gray matter capture with the electrodes. So really at this stage, our method is providing equivalent or slightly better trajectories looking at these measures. And finally, we can perform a qualitative evaluation of each plan by looking at the spatial arrangement of the electrodes. And what you'll see in this video is that there's one pair of electrodes that are quite off, and then there's some things that the algorithm does that are subtly different. So for instance, the hippocampal electrodes we always place slightly more anterior, and this is due to blood vessel location. And in this example, our orbital frontal electrode is much more posterior, and that's really to avoid this blood vessel here that the surgeon, the manual planned electrode, is quite close to. And if we get rid of the cortex and play this video again, what we can see is that the electrode pair here that's quite off is actually due to the target point shifting, and that's because the target point was shifted due to this quite large blood vessel here that the manual plan was near. And so to conclude, our method, we can find safer trajectories that are farther from blood vessels than the manual plans. We also have higher efficiencies. The electrodes are placed in gray matter, so we can record more brain signals from the contacts. And we also have faster planning. We're doing these plans in minutes versus the hours it typically takes the surgeons. But there are also some things that remain to be done with this work. The biggest is that we've just looked at quantitative measures here. We really need expert neurosurgeons blinded to plan origin to assess these plans and give us feedback as to whether or not the computed plans we're providing are actually surgically feasible and preferred by the surgeons. And this is ongoing work. Another thing that we can do is incorporate knowledge learned from historic implantations. So for instance, we might want to alter consates depending on which target anatomy we're looking at. And one example of this is a manual plan, and what you can notice is that the orbital frontal electrodes typically have a greater entry angle compared to the rest of the electrodes, and this is because surgeons prefer placing the orbital frontal electrodes on the crown of the skull. And I'd like to end by thanking my sponsors.
Thanks a lot. The paper is open for discussion. Yes, please, Leo.
Thank you for a nice presentation. One of the controversial measures for surgeons is the risk measure. Obviously, the blood vessels are one of them, but the size of the blood vessel is another consideration, and there are other functional data that might be available. We found that defining a risk measure was very controversial and sometimes even offensive to some neurosurgeons who said, okay, that's one measure. Could you comment on your experience with the reaction of the neurosurgeons to this risk function?
Yeah, so in our case, the risk measure is only looking at proximity to blood vessels along the trajectory. And we also provide what we call an electrode profile. So we essentially show them along the electrode how close we are to the blood vessel at every point. And I think at this point, because there's such close correlation between what the surgeon can see on that electrode profile and the risk score, they're becoming more accepting of it. But I think just providing the risk score alone is not enough. You also need to provide them sort of more intuitive information as to the location of the blood vessels for it to really be accepted. And they also have to see good correlation between what they can see on the plans and the risk score. So I think, like you said, it is quite controversial.
Yes.
Thanks for a nice talk. A question and a comment. The question is, you only showed pictures of the cerebral veins. The arteries are a much smaller target, but more important if you hit one. And the comment or the suggestion is, although you'd need to accumulate a lot of cases, just keeping track of where there is a recorded hemorrhage, for example, from a post-procedure scan, will be really important data to validate the really useful things you're doing.
Yeah, so in terms of I guess the sort of question about the veins and the arteries, and most of the examples I only showed the veins simply for clarity purposes, because the arteries are so much smaller and more densely packed. It's quite hard to actually see where you're sort of going because there's so many more arteries. And in terms of the other comment, in this case we did a retrospective analysis, so we're comparing with plans that were already implemented, but in the future we're going to try and do prospective work, and then we'll clearly do the tracking with the hemorrhage and the complications.
Thank you. So, sorry, Ross, we have to move to the next story. This is my job. Thanks again, the speaker.
So the next talk is Robust Image Descriptors for Real-Time Intra-Examination Retargeting in Gastrointestinal Endoscopy. It's a collaboration project between Imperial College London and Ulm University, and it will be presented by Menlong Ye.
Good morning, everyone. I'm Menlong Ye. I'm from the Hemi Center for Robotic Surgery in Imperial College London. I'm going to present our work, Robust Image Descriptors for Real-Time Inter-Examination Retargeting in Gastrointestinal Endoscopy. So endoscopy has been the gold standard for visualizing the human dry tract. Serial examinations have been used for monitoring the tissue abnormalities. Recent advances in imaging modalities, such as narrowband imaging, confocal laser imaging, have enabled optical biopsy to be used for in vivo in situ and real-time pathology analysis. However, there exist difficulties in endoscopic examinations with optical biopsy. It is challenging for the clinician to retarget consistently a biopsy location during one examination, which is termed as intra-examination retargeting. Retargeting in between examinations, which is termed as inter-examination retargeting, is even more challenging. As you can see from these videos, this is because of the local tissue appearance changes, as well as the fast camera motion. For intra-examination retargeting, there are several approaches proposed in the past years. They are either based on feature matching or region tracking algorithms. For achieving inter-examination retargeting, which is also the aim of this work, there are two frameworks proposed. The first one performs manifold learning to learn a low-dimensional representation of the diagnosis video. The second one uses multiple external positioning sensors to achieve retargeting. However, this might interfere with the clinical workflow. In this work, we propose a vision-based framework for inter-examination retargeting. We formulate this problem as an image retrieval task which can be divided into two phases, training and retargeting. For the training phase, we extract the image descriptors from the diagnosis video, and then we compress them into short binary codes. This then forms a binary code database. Using this binary code database, along with the descriptors, we then train an encoded function based on random forests. For the retargeting phase, we have a query image from the surveillance video, and then we extract its global image descriptor, and then we encode this descriptor into a binary code using the trained random forests. We then search this binary code in the binary code database, and it finally returns the relevant images from the diagnosis video to this query image. The first step of the training phase is image description. As I mentioned in the introduction, endoscopy scenes might undergo local tissue appearance changes. Using key point-based description might not be robust for this case, such as backwards. Therefore, in this work, we propose to use a global image descriptor that aggregates local regional binary patterns. For a given image patch, we divide this patch into 3x3 regions, and then we average the region intensities. Then we got the intensity number, and then we perform 4 diagonal comparisons to obtain a 4-bit binary string. This string is then converted into an integer ranging from 0 to 15. To consider the global geometry of an endoscopy scene, we applied spatial pyramid pooling. We have used a 3-level cost-to-find representation. For a given image, in the first level, we scan the local binary pattern of the entire image to obtain a 16-dimensional histogram descriptor. In the second level, we divide the image into 2x2 partitions with the additional partition overlapping the center, and this generates 5x16 dimensional descriptor. In the third level, we divide the image into 4x4 partitions with additional 3x3 partitions overlapping, and this provides us 25x16 dimensional descriptor. Finally, we concatenate all of this together to form a descriptor which is 496 dimensions for the images. During surveillance examination, retargeting of a query image is required to be real-time, such that the regular clinical procedure will not be interfered. Inspired by the computational efficiency of hashing-based image retrieval, in this work, we follow a two-stage hashing technique to compress our descriptors into short binary codes. And this is achieved by sequentially optimizing a loss function for each bit of the binary code. We used a quadratic hinge loss function for this optimization, which encourages the Hamming distance between two images of the same scene to be small, while to be large for the images of different scenes. For the optimization, we have used the graph card algorithm. To obtain a binary code of a query in the surveillance video, we need to first learn an encoding function from the descriptors to the binary code. In this work, we use random forests as this encoding function. For m-bit binary codes, we train a number of m random forests, with each random forest corresponding to 1 bit. As you can see, the extracted descriptors and the binary codes from the diagnosis video are used to train the individual encoding functions for each bit of the binary code. Each random forest in our work consists of 100 decision trees with a maximum depth of 10 for each tree. Tree growing is performed via maximizing the information gain where the Shannon entropy is used. After training phase, retargeting of a query image is performed sequentially by descriptor extraction, binary code encoding, and Hamming distance searching in a diagnosis video, and this finally returns the relevant images from the diagnosis video to this query. To validate our approach, we have collected 13 in vivo GI videos from 6 patients using an Olympus narrowband imaging endoscope. For the first 5 patients, we collected 2 videos for each in serial endoscopies. For patient 6, we have 3 video collected in 3 separate examinations with a time interval of 3 to 4 months apart. We used to leave 1 video out cross-validation. In total, 16 experiments were performed with retargeting of 50 randomly chosen query images for each experiment. Currently, the query time is on average around 19 milliseconds, and this meets the requirement of the real-time retargeting. We compared our descriptor to some state-of-the-art descriptors. We also have tested our framework with different hashing techniques. We also compared our approach to a previous retargeting approach based on manifold learning. Here are some of the qualitative results. The query images in the surveillance video are indicated in the yellow border images, and the correct retargeting results from the diagnosis video are highlighted in the green borders, and the wrong retargeting results are highlighted in the red borders. Here are some more results of the retargeting. One thing I'd like to mention here is that currently our framework does not explicitly address the rotation invariance. However, it does allow for a certain degree of rotations. Also, a quick solution to achieve rotation invariance is to perform data augmentation, such as rotating the images before descriptor extraction. This is a video demonstrating how our framework can be integrated into clinical workflow. As you can see, the clinician can select the image to retarget from the surveillance video shown on the left side, the right side, and then our framework can then return the relevant images from the diagnosis video on the left side. As you can see, our framework can be readily incorporated into current clinical workflow. We compared our descriptor to state-of-the-art descriptors, including bagel words based on SIFT and the GIST descriptor, as well as a recently proposed BACT descriptor. We have performed precision recall analysis. The results of our method are shown in pink curves, and it outperforms all the others. We have also tried different lengths for the binary codes, and from our experiments, it turns out that 64-bit performs the best. That's the reason why we used it for all the other experiments. Precision recall analysis was performed for the hashing techniques. The results of our method are shown in pink curves, and it outperforms all the others from our experiments. This is a table presenting the mean average precisions, both for the descriptor comparison and the hashing framework comparison. As you can see, both our descriptor and the hashing-based method outperform the state-of-the-art. In addition, binary encoding has improved the retargeting performance over using the original descriptors. Okay, to conclude, in this work, we presented a new retargeting framework for optical biopsy. We have designed a global image descriptor with regional comparisons over multiple scales to deal with the tissue local appearance changes. A novel binary encoding function via random forest was used, which adds the discrimination ability and also speeds up the retargeting. Our framework can be readily incorporated into existing clinical workflow due to the accuracy and the real-time retargeting capability. Validation on in vivo videos of serial endoscopies has shown that both our descriptor and the hashing scheme are consistently state-of-the-art. Thank you very much, and I'm happy to take questions.
Very nice presentation, thank you. The paper is open for questions.
I have a question. Thank you very much. I have two questions, actually. The first one is, what is the time interval between the two serial exams that you make? Is it the same day? Is it 3 months apart?
Yeah. So as I mentioned, we have 6 patient data. So for the first 5 patients, we perform 2 endoscopies in same examination. So you have endoscope pulled in and pulled out for that. Okay. For the patient 6, we have 3 videos, and they are collected with 3 to 4 months apart.
Okay, because for the quality of the results, it might vary a lot if you take exams several months away, and this can change a lot the performances.
Yeah.
My second remark is about the rotation, which is a very important feature. So you said you could deal with the rotation by doing data augmentation. How many additional images you believe you would have to add to the system to take into account the rotation?
So actually, in our framework, the current one, we haven't really do the data augmentation yet. But if I'm going to do it, I think I'm going to partition the 360 degree into 8 partitions, rotate with 8 divisions, something like that.
Okay, thank you.
Thank you.
We have time for one more question.
Thank you for your talk. I was interested to know that how did you perform your comparison with SIFT method. The first step of your method was very similar to SIFT, but I believe that SIFT is better in compensating for rotation and scaling. What sort of experiment have you done for your comparison in the last step?
So the bigger words is based on SIFT features. So in our experiments, we used the 10,000 dimensional dictionary for the backwards method. And one thing we have found, so in our experiments, we found is actually the local features that are not very stable, because the SIFT you have to detect the key points first and then perform the description. But in our case, we might see some tissue appearance changes. That is the reason why we found SIFT and backwards were not performing well.
And do you think if you increase the duration of the recording, would you get the same result?
Sorry, increase what?
The duration of your recordings or your video recordings.
Oh, I see what you mean. Yeah, but that is not our choice, it's clinicians. It's their decision, like if they want to record more. But it might help.
Okay, thanks.
Yeah, we'll have to try. Thanks.
Okay, so let's thank the speaker again.
It's quite frustrating at session chairs not have time to have any questions, but we try to stay on time. So it's time for the next talk given by Shekufe Azizi. It's about recognizing cancer grades from ultrasound images.
Good morning, everybody. My name is Shekufe Azizi from the University of British Columbia, and today I'm going to talk about classifying prostate cancer grade using temporal enhanced ultrasound data. According to American Cancer Society, 1 in 7 men will be diagnosed with prostate cancer during his lifetime, where the definite diagnosis of prostate cancer is core needle biopsy, which is typically guided under transrectal ultrasound or TRUSP. Basically, either using systematic biopsy or using MRI transfusion biopsy as a state-of-the-art method, currently we are dealing with high rate of unnecessary biopsies. And if you recall from the yesterday keynote, and ongoing challenges in prostate cancer diagnosis is to reliably detect clinically significant prostate cancer. So our overarching goal is to use a new technology, basically an ultrasound-based method, to generate cancer likelihood map overlaid on a TRUSP image, so we can use this color map to target the region with the reading of the aggressive prostate cancer. So toward this goal, our group has been working on a method called temporal enhanced ultrasound, which is defined as the time series of the RF co-intensity obtained from a fixed tissue location over a multitude of TRUSP frames. Basically, in the MICCAI 2015, we proposed a feature learning method, a deep learning-based method, to extract tissue-dependent feature for detection of the cancer versus benign tissue. So we can generate this type of binary map for targeting the prostate cancer region. But having in mind our ultimate goal, which is the prostate cancer grading, we took a step forward and we further analyzed our learned feature from our deep network, and we had an interesting observation here where the ROIs coming from the aggressive regions tend to shape a cluster in our feature space. So it raises a question if we can use this information for PCA grading. But before answering this question, I would like to make it more clear that prostate cancer grading isn't a trivial task, and we have lots of challenge for that. Basically, here you can see a pathology slides coming from the histopathology. Basically, they are coloring the region based on Gleason patterns, and when they are taking a biopsy sample from a region, basically reporting the aggressiveness of the prostate cancer as a summation of the first and second dominant Gleason pattern that they can observe in the region. Basically, we have benign versus cancerous region, and where we have more Gleason pattern 4, we're moving toward more aggressive tumors. But what is the problem with this type of reporting system that we're using it as our ground truth label is that we don't know the exact location of the cancer in our regions. And when we have combination of different Gleason pattern, we don't know the exact location of each pattern. And also we have some unreported tissue types because the prostate cancer basically is heterogeneous and multifocal. So recalling from our learned feature space and our observation to solve the problem, basically we're trying to learn distribution in our feature space. We are starting with the benign samples, and basically we can at least see 2 different clusters in our feature space for benign samples. So we are detecting the benign cluster in our feature space, and by adding aggressive tumors with the reading of Gleason pattern 4+4, we can learn the distribution of Gleason pattern in the feature space, and after that, using more sample from less aggressive tumors, we are learning the distribution of the Gleason pattern tree in our feature space. So to put everything together, we're using our training data sets to basically learn differentiating feature between the benign and cancerous region using a deep belief network. And after that, by learning distribution, we can create a clustering model to use for the test data. When we have a new test data, using our train model, we can assign a label to each region of interest. And after that, when we have more Gleason pattern 4, we are calling that sample as an aggressive sample. To test this idea, basically, we are obtaining our data in a collaboration with Phillips Research North America and the National Institution of Health, NIH at Maryland, during the MRI transfusion biopsy. And basically, we're obtaining test data from the MR identified locations. And we have access to 197 trust-guided biopsy core from 132 subjects. Using this data set, these are the results. Here you can see the interclass area under the RC curve. And basically, for detection of the benign versus clinically significant PCA, we achieve area under the RC curve of 0.8. In another step, we are combining our methods basically with the readings from the multiparametric MRI and taking advantage of both modality. Basically, as you can see, we have an increase in the accuracy of the method. Also here we have cancer likelihood map that we can generate using our method, target location and the segmented boundary of the prostate is co-registered from the MRI, and blue showing the benign, detected benign regions, and when we are going from yellow to red, we are moving toward more aggressive tumors. One of the interesting samples that we have is this actually target where they're taking 2 biopsy samples from one location. The first reading, the first samples basically return as a less significant prostate cancer, but when they're targeting again the same location, they're showing, basically it shows that we have an aggressive tumor there. But if you looking at the color map that we are generating for this target, basically the clinician can reorientate their needle in the first sampling and capture the aggressive region by just taking 1 sample. Here you saw some interesting results from our method, but what we were really interested in was the physical phenomena basically governing TIA's interaction with the tissue. So from our submission to MICCAI, we work on the physical part of the method, and I would like to present some of our recent findings. Basically, using our deep network, we backpropagate the learn feature to our spectral domain, where we have 15 spectral components, and basically our result indicating that some of the low-frequency components contribute more in detection of different glycine pattern, where they are in the range of cardiac pulsation. So our main hypothesis is that micromotion due to pulsation can change a speckle pattern depending on different tissue structure. To test this idea, basically, in another data set coming from the Colorado University, we access to digital pathology, and we can extract nuclear location from the digital pathology coming from different glycine pattern, and putting this nuclei in a finite element model, we are pulsating them with a low-frequency signal, and after that, using fill tool, we can generate the same signal that we are using in our real data. And these are the simulation results, and basically, if you're comparing this result with the result that we have from our deep network, you can see that simulation result completely support our observation in the real data. To conclude, in an in vivo study, including 197 trace-guided biopsy, we achieved the area under our curve of 0.8 for suppression of clinically significant prostate cancer versus normal tissue type. But we still consider this study as hypothesis-generating study, and obviously we need to further verify in larger population and further investigate the underlying physical phenomena. But I would like to leave you with one final message. Think about how this technology can change the roadmap of prostate cancer diagnosis. Thank you so much.
Thanks a lot, Shikufe, for this great talk. The paper is open for discussion, so don't stop asking questions after what I said previously. Yeah, please.
Hello. I thank you very much for the presentation. You have mentioned about the cardiac pulse, correlation with cardiac pulse. Is it possible that the observed effect is coming from the tissue biomechanics? Basically, you are maybe doing elastography, where the breathing or the cardiac pulse is actually just the excitation source. Is there any relation with that?
Basically, what we are doing in our simulation is to suppress the effect of elasticity, basically. But basically, what we have in elastography is that when we have a stiff tissue, we can observe a different pattern. But what we have here is basically due to tissue microstructure in very early stage of the cancer. So we believe that what we are observing is something different from tissue elasticity or something like this.
Thank you.
Any other question? So I may have one. So the reference you use to compute the ground truth you use to compute the AUC is coming from the histopathology?
Yeah, but basically our ground truth is coming from the histopathology. We know for each of the biopsy core what is the reading of the histopathology, and we basically compare it in interclass AUC, benign versus clinically significant PCA, which is greater than 4+3, and benign versus less significant PCA, which is less than 3+4. Yeah.
Okay. Does the biopsy by itself does not change the anatomy where you
the anatomy?
Yeah, the effect of the biopsy by itself, it's
I don't get your question. So can you explain more?
I'm thinking about the bias, possible bias of the ground truth, where how the biopsy is performed exactly. So
yeah, actually.
The needle.
Yeah, actually, I think basically mismatches between the reading from the biopsy or the registration error can affect our results, and we need to further investigate different parameters that have effect in our study.
Any other questions? No. So let's thank the speaker again. Thank you.
Okay.
The next talk is entitled 2D, 3D Registration Accuracy Estimation for Optimized Planning of Image-Guided Pancreatobiliary Intervention, and it will be presented by Yipeng Hu from UCL.
Morning, everyone. I'm Esther Bonmati. I'm the second author of this work. Yipeng sends his apologies due to family commitment. I will start by introducing the clinical background. So pancreatobiliary interventions are endoscopic procedures that involve the biliary tree, which is shown as in green in this 3D image. And as we can see in the image from the middle, in these procedures, the endoscope is inserted through the mouth to the stomach, and then different tools are inserted in the ducts. And from at this point, the procedure is guided by using a C-arm, which is the device that you can see at the top right. And the images acquired by the C-arm are kind of X-ray images. You can see an example at the bottom right. Usually these images are taken after injecting some contrast in the biliary tree. And the position of the C-arm is very often positioned by having no prior information about the best position of the C-arm. Intraoperative ERCP has some problems. So for instance, if there is any stricture or something that is blocking the duct, when the contrast is injected, we cannot see what's the information beyond this point. So we solve this problem by using MRCP. This is a modality very similar to MR. In this case, the ducts are highlighted. So by registering these two modalities, we can have a better idea intraoperatively what's beyond the point and what's the information and the anatomy that we cannot see. So ERCP has limitations. It's a 2D projected image. It needs contrast and also radiation dose. So 3D guidance is useful, and it also might imply to take less amount of images, but we need the registration to be accurate and precise. But this work is focused on estimating the registration accuracy. This accuracy has different sources of uncertainty that I will show later. And we do this to know the confidence that an operator can place to the registration results intraoperatively, and also to optimize the C-arm orientation during a preoperative plan. The second part of this talk will be focused on planning uncertainty. I will show how this can assess an interventional plan, and I will show an example using the C-arm and how this can help clinically. And we will see that for some patients, the C-arm position is important, but for some other patients, maybe the C-arm position is not that important. So we start first doing a 2D, 3D landmark registration. So first we have to define the landmarks in the 2D space using the ERCP images. We also define 2D targets, which we also use for validation. We have to define also the 3D anatomical landmarks in the MRCP volumes. Additionally, we perform an automatic segmentation of the biliary tree, but that's only to assess the landmark positions and also for visualization purposes. And then we perform the registration, the 2D, 3D rigid landmark registration in this case, and we start the guidance. So the first part of this talk will be focused in the TRE error estimation. And as I said before, we want to do that to know the confidence that an operator can place with the registration results. In this flowchart, you can see all the errors involved in this TRE estimation. We start by defining the 3D landmarks. We do so in separate occasions and also by multiple observers. We get the covariance of these 3 landmarks and also the covariance of the targets, and then we propagate these covariances in order to get the error of the registered target. Then, also by minimizing the error in the registered target, we can also optimize the C-arm orientation, which we will see in the second part of this talk. So the main technique that we use to propagate the errors is the forward and backward propagation. Forward propagation is a process where we map the uncertainties of the inputs of a function to the outputs of a function, and vice versa for the backward propagation. So starting from the point that the 2D images are produced by projection, we have a vector U, which defines the position of the 2D landmarks, and theta, which are the registration parameters, and K, the camera intrinsic parameters. And then by doing backward propagation, we can propagate the uncertainties of the 2D points to the uncertainty of the registration parameters. However, this is how it has been done before, but it does not consider the localization uncertainties of the 3D landmarks. So in this work, we propose to create a new function which considers the 3D landmark positions as parameters of the function and also as outputs of the function. And then by doing backward propagation, we can backpropagate the uncertainties of the 2D, but also the uncertainties of the 3D to estimate the uncertainties of the registration parameters. From this point, we can estimate the TRE by just using forward propagation. Here, a more visual example, we can see in A that the C-arm is moving, and the view of the anatomy according to the C-arm is also changing, which we can see in B. And if we take the projection of this anatomy, which we can see in C, the orange ellipse represents the uncertainty of the TRE, in this case of the target. And we can see that while the C-arm is moving, this TRE is also changing, so it's increasing or decreasing depending on the position. And just for reference, in blue, we can see the uncertainties of the landmarks. Here, there is a video of the interface that was developed in this project. We can see now the MRCP volume, also the automatic segmentation of the biliary tree. And then when intraoperatively we receive an image, we can see also this image online. And once the clinician is happy with the image, we define the 2D landmarks in this ERCP image. This could be the hylium, the ampulla, or other anatomical landmarks. And once the clinician has defined all of these landmarks, we perform the registration. And at this point, we can move through this ERCP image and see the corresponding point in the MRCP volume. So we have seen so far how to estimate this TRE. And by minimizing this TRE, we can also find the optimum C-arm orientation. The second part of this talk is focused on the planning uncertainty. In this case, and by using the same strategy, we want to propagate the errors in the registered target and also the C-arm position and the patient positioning, and also the errors in this patient positioning in order to find the error in the planned C-arm. So the idea behind this, the second part is assuming that the patient might have some patient positioning, for instance, there might be some motion, how does this affect to the C-arm position? Is it still the same or is it a completely different one? And to do so, we use the same strategy. In this case, we backpropagate the uncertainties of the registration and also the uncertainties of the patient positioning, and we have now the uncertainty in the C-arm position. And this allows us to estimate how precisely the C-arm position can be planned to achieve an optimal estimated TRE at the time of planning. And of course, deciding whether the estimated planning error is clinically acceptable or not should also consider whether the registration accuracy is clinically acceptable. For instance, if there is a procedure that accepts a larger TRE, we can also accept a larger planning error. And in this image, we can see two visual examples of small planning and large planning. So on the left, we can see a case with a small planning uncertainty. For this patient, a very narrow range of C-arm orientation. By using this narrow range, we will get a small TRE. But we have also a second case with a large planning uncertainty. In this case, there might be two possible scenarios. It could mean that for a large range of C-arm positions, the TRE is always the same, or it could also mean that the optimum C-arm position is changing. So for the second patient, it's probably not that important to have an optimum C-arm position, but it's because it's unlikely to change the TRE. To verify our method, we compare the TRE estimation using our method with 10,000 Monte Carlo simulations. Here we can see the results with two different cases. And the columns and the rows represents the position of the C-arm. If we have a closer look, we can see in a black solid line, this is the result of the Monte Carlo simulation. And in a color ellipse, this is the result using our method. We can see that the fit is good. And we also test this method using retrospective data. In this case, we have two patient data. Each patient has two images, so the first two rows corresponds to the first patient, and the second two rows corresponds to the second patient. We can see that for the first patient, we have a small planning error, which is also confirmed by having different TREs. And for the second patient, we can see that we have a large planning error, and for these two plans, we have the same TRE, which is not changing. And also, from these results, we can see that our estimated TRE is smaller than the observed TRE. We believe that this is because the rigid registration, but what's important from these results is that the value seems to be correlated, and when the estimated TRE is small, also the observed TRE tends to be small. And as a conclusion, I have presented a new error propagation approach, which incorporates uncertainties in 2D and also 3D to estimate the TRE. We have shown the uncertainty in planning, which is introduced to assess the planning of the C-arm preoperatively. And we have also shown preliminary results from real patient data. And finally, I would like to thank the team and also our founders. And as a second author, I'm happy to take some questions.
Thank you very much. This was very well on time. The paper is open for questions. So maybe I start. Pierre, you scared them off. What do you think has a greater impact on the error? Is it the configuration and number of the landmarks or the C-arm pose?
So what we do in this work is to estimate the TRE during intraoperative plan. So if it depends on the C-arm, it will also depend on the localization of the landmark. Obviously, we can estimate this TRE and we can optimize the C-arm position for a particular position of this landmark. But then we will see that if we move on the image, we also get different TREs. So it not also depends on the C-arm. It also depends on the position of the target.
Sure. I was just thinking that maybe in the future you could extend your approach and suggest regions where to place additional landmarks such that the expected TRE would be minimized.
That's a very good thing, actually, and we haven't tested that yet, but we will consider that. Thank you.
Okay.
Nice seeing someone trying to estimate registration errors, which is not easy. So you do it you do the registration estimation from one slide 2D, 3D registration, and then you assume it has the same performance for other C-arm positions. Is this correct?
Yes, that's correct. And at the moment, we don't have that much data, so we only have 2 patient data. And that's correct that we only use the landmark uncertainties for these 2 plans, for these 2 images. But we believe that in the future, we will have more patient data, which we already have, actually. And with that, we can have a better idea for each kind of landmark, what's the uncertainty. So we will
how the image content might influence that, and maybe then you get the estimate closer to the true TRE.
Yeah, we might have a better estimate TRE by doing that, yes.
Okay, great.
We have time for one more question.
How do you, how do you explain the results where it seems that you underestimate the TRE compared to the observed one? What is your explanation of?
Yeah, so the first reason we believe that is because we're using a rigid registration, so that might introduce more error. But it could also be because the estimation with the Jacobian is linear, so there might be some approximation issues there as well.
Okay, so let's thank the speaker again.
So we move to the next talk, which is about recognition of activity or surgical activities, and it's given by Robert DiPietro.
Okay, hello everyone. So I want to talk today about trying to automatically recognize surgical activities from robot kinematics, and this is joint work with our lab at Johns Hopkins, the Computational Interaction and Robotics Lab. Where is the green button? Thanks. Okay, so one of our main goals in the lab is to try to develop methods to model and evaluate surgical skill. And one driving force behind this is robotic minimally invasive surgery. So here it's pretty difficult for trainees to learn. It's also difficult for experts to mentor, and it's really difficult for anyone to assess performance in a way that's very consistent and quantitative. So 2 major questions that we have are, can we assess performance in a way that's both quantitative and consistent? And also, can we provide automated feedback to trainees? So in this work, we're going to specifically focus on a first step toward those questions, which is, can we recognize activities automatically over time? The main idea here is that if we can automatically localize activities and recognize what those activities are, then we can analyze each activity in more detail to provide activity-specific assessment and feedback. So here I'm showing robot kinematics on the top. So this is going to be a vector over time of, for example, positions, velocities, etc. And our goal is to infer activity labels. So here each color is a particular higher level activity. Okay, so eventually we'd like to provide feedback and assessment at multiple levels of granularity. So here are 3 examples. So in prior work, we focused on recognizing gestures. So picture very short, low-level activities, for example, grasping a needle. In this work, we also focus on maneuvers. So these are essentially compositions of gestures, which are inherently more variable. They're longer, and as we show on the bottom, they're compositions of gestures, so there's naturally more variability there. And in future work, we'd also like to address the task level. So for example, picture closing of a wound, which then actually is going to be a composition of maneuvers. Okay, so formally, in this work, we're going to be given a vector, or a sequence of robot kinematics as a sequence of vectors. And each vector, again, is going to consist of, for example, positions, velocities, etc. And the real goal here is for every time step to assign a particular activity label, which here is going to be an integer. And really specifically, what we'd really like to do in this work is train on one set of surgeons, but have the algorithm be able to generalize to other surgeons that were never actually present during the training set. Okay, so prior work has addressed gesture recognition, and they've typically done this with conditional random fields, which includes the state-of-the-art method. And the idea here is that we would like to essentially capture the activity labels given the kinematics using essentially two terms. So the first of these unary terms, and this essentially measures a compatibility between labels and the kinematic. So think of this as what the kinematic tells us alone, okay? And how we do this in practice is we specify some feature functions to relate similarity between labels and the kinematic inputs. Then we essentially let our model have the freedom to weight these feature vectors, and these are the parameters that we're going to learn. Now these give us unary scores at each time step, and then what we do is sum up those scores to have a sequence level score, and then we exponentiate and normalize, and this will give us a distribution over our entire activity label sequence given our entire kinematic sequence input, okay? Now conditional random fields typically include higher order terms, for example, pairwise terms, but in this work we'd really like to focus on the unary terms, and the main question that we'd like to ask is, does it make real sense to say that our similarity should only depend on the current kinematic vector? So in other words, shouldn't dynamics be able to teach us something about the current activity label? And the state-of-the-art work, which is the latent convolutional skip chain CRF, does address this in a better way. So they essentially form linear combinations in a time window around the current time point. And so this does a better job, but it's still local in time, and it's also linear in the model parameters. Okay, so the main question in this work is it possible to form unary scores that actually capture more complex nonlinear dynamics over time? Now the problem is that if we were to do this with conditional random fields, we as modelers would need to specify these feature functions, and this is extremely hard to do and impractical essentially, so that's why it has not been done in practice. So instead what we're going to do is turn to recurrent neural networks. So why recurrent neural networks? The real answer here is that they've been so successful for so many sequence modeling tasks. So for example, we use them daily without maybe really knowing it, like in the Android speech recognition software, but also they've set many benchmark records, for example, speech recognition and handwriting recognition. Okay, so how do recurrent neural networks work? The main idea here is that we're going to maintain a hidden state, and this hidden state is going to be responsible for capturing all of the dynamics that are relevant toward our end goal, which again here is activity recognition. So what we do is we compute some hidden state, then we use that to compute a distribution over our current activity given the current kinematic vector. Then what we do is we observe a new kinematics vector. We use that along with the previous hidden state to compute a new hidden state, and we use this to compute a distribution over the current activity label given the current and previous kinematics. Now we repeat this process, and so the main message here is that we're actually modeling the probability over our current label given our entire history of kinematics instead of just a surrounding window. So how do we actually compute the hidden states here? So at any time step, we're given the input xt and the previous state, ht minus 1. We apply a linear layer, and then we apply a nonlinearity, and this gives us our new hidden state. Notice here that the widths of the W's are fixed, but the height is actually a hyperparameter, and this specifies the dimensionality of h, and it's also referred to as the number of hidden units. Now we're going to be interested in transforming from our hidden state to a distribution over our current activity label. So how do we do this? The first step is to essentially learn a dimensionality reduction that will take us to a dimensionality that's equal to the number of activity classes. And then just like in conditional random fields, we're going to exponentiate and normalize, and this will give us a distribution over our activities. And in fact, the ith element of this vector is exactly the probability of the of this time step being the ith activity. And I emphasize again here that we're conditioning this activity on all of the previous inputs. Now, if we're operating offline, we can actually also use future information, right? There's no reason to restrict ourselves to the past. So in this case, we can use bidirectional recurrent neural networks. So what we do here is we observe the entire input sequence. We run one recurrent net in the forward direction, one in the reverse direction, and then we concatenate the hidden states. And this instead lets us form a distribution over the current activity label given all of the kinematic inputs. so for each individual activity label. Now there's one problem here, which is that if you actually try to train the architecture that I showed in the previous slides, it will just fail because of what's known as the vanishing gradient problem. So in this work, we circumvent this by using a common architecture called long short-term memory. We're not going to go over the details here, but I really would like to emphasize that the main point of LSTM, it was designed specifically to avoid the vanishing gradient problem, and it's actually possible that other simpler architectures work too. So the loss, because with recurrent neural networks, we actually assume that our probabilities for each label they're independent over time as long as we're given the entire sequence of kinematics. And because we make this assumption, maximizing the likelihood in our model is exactly the same as minimizing the overall cross entropy. So that's the loss on top. And we can train this using stochastic gradient descent, and we can compute gradients efficiently with backpropagation. Okay, so let's look at some experiments. So we're going to deal with two different data sets. The first tries to recognize gestures, so again, these lower level short activities. And then the second data set, we're going to try to recognize maneuvers, these longer, higher level activities. In both cases, our inputs are going to be identical, which are also the same as the previous state-of-the-art's inputs in the published work, which are positions, velocities, and gripper angles over time. Okay, so we are going back to the original goal. What we're really interested in doing is trying to generalize to surgeons that were never present in the training data. So that's what we're going to do here. So we're going to have some number of users, and for any particular trial, we'll leave one user out, train using all the others, and then test on the left out user. And then we're going to report results over all trials. So here are results for gesture recognition. So on the top, we see the state-of-the-art method, the latent convolutional CRF, skip chain CRF. And we have two measures of performance here. The first is accuracy. So this is essentially just the percentage of correctly classified frames. But we also have edit distance, which is a more global measure. This is essentially, it's related to the number of operations required to transform from segment level labels of your predictions to segment level labels of your ground truth, okay? And the higher the accuracy, the better, and the lower the edit distance, the better. So here what we actually find is that the results are essentially identical. So we did run statistical significance tests, and in this case, there's no real difference between the bidirectional LSTM and the latent convolutional skip chain CRF. But one thing I do want to point out with this slide is if we look at the quantitative results, we can actually see that our predictions are smooth, even though we never explicitly modeled the fact, we never modeled any sort of structure on top of our labels, right? We assume that they're independent over time, given the kinematics. And this is something that the higher level structure is typically always something that's included in conditional random fields. So for the maneuvers data set, we actually do find a significant difference from the state-of-the-art method. So we improve from roughly 82% accuracy to about 89% accuracy, and we reduce edit distance from about 30% to 20%. And in this case, we only have 4 activities that are more interpretable, so I'll just list them here. So in the black color here is suture throw, the blue is knot tying, the green is grasp, pull, run suture, and the yellow is intermaneuver segment. And notice again that we see what seems like a lot of structure in the predicted labels, even though we never explicitly modeled that structure. Okay, so to summarize, so as far as we know, this is the first application of recurrent neural networks to surgical activity recognition, and we obtain state-of-the-art performance without ever including any explicit structure over our labels. In future work, one thing we'd of course like to do is use visual information in addition to the kinematics to improve results more. And also one interesting future work is to actually put that structure from the conditional random fields back in. So what if we use recurrent neural networks for the unaries, and then we also include more structure on the data to get better results? And I'd like to emphasize too that the code is available here, so you can find it all on GitHub. Okay, thanks very much.
The paper is open for discussion. There's probably a question around. Nicolas, for example, do you have any questions to raise? Let's wait, yeah.
So you cited some work from the 90s for some of these memory techniques. So I'll give you one 15 years old perhaps that talks about turning actions into objects for recognition. in the computer vision world. So I wonder, and in particular, a result that says that actions can be modeled as generalized cylinders. So I wonder if shape recognition and matching techniques could have been relevant here as well. Have you explored those?
So one thing I'd like to emphasize, you mean in vision, right? Particularly for vision. So in this work, we're only using kinematic data, so no vision at all. So we have not yet explored using, for example, particular techniques for vision for this task. Other works have been done, but I will mention that actually the kinematics only result in this work and prior work actually outperforms the state-of-the-art methods that used both the kinematics and the vision data. Mm-hmm. So that's something we're going to, it's an open problem, so we haven't yet dealt with the vision data.
Okay.
I have a quick question. Mm-hmm. If, I'm here, I'm the chair. So, if a surgeon was to annotate your data, what accuracy would that person get? What do you think?
I cannot answer that question easily. I wish my co-authors were here who would be able to answer that question very well. I can't give an estimate yet.
May I just ask something? I'm here, I'm the chair, I'm the second one. It's a joke. What is your next step to go towards the application? So you took, what is the next step, your next step to go towards the application? So you say...
you mean the end goals?
Feedback and assessment, and so what will you do towards this after the segmentation and the recognition?
Yes, so we have not yet got to that step, so this is essentially a preliminary work, and I'm still personally interested in this problem and how good can we get activity recognition before we essentially move to the next stages. So I have not yet done any work toward those end goals.
Okay. Yes, thank you. Let's thank the speaker again.
We have one last talk. It's entitled Two-Stage Simulation Method to Improve Facial Soft Tissue Prediction Accuracy for Orthognathic Surgery, and it will be presented, I think, by Mr. Kim.
Thank you for the introduction. Good morning, everyone. My name is Tae-Seung Kim, working for James Shar at Department of Oral Maxillofacial Surgery at Houston Methodist Hospital. I would like to talk about how facial soft tissue changes after jaw surgery. Orthognathic surgery was developed to solve functional and aesthetic problems of the patient with dentofacial deformities. It's the bone-only surgical procedure. It is performed by cutting jaw bones into pieces and reposition them to a desired position. Facial soft tissue changes as a result of the bone movement. Facial soft tissue change is one of the major concerns of the clinicians and patients. However, accurate prediction of the facial soft tissue change is challenging because of the complexity of the facial soft tissue anatomy. Different types of the techniques were developed to solve this problem. Among those, FEM was reported to be the most common and accurate simulation method. However, there are some problems with the current FEM simulation. Firstly, it assumes a rigid relationship between bone and soft tissue. No sliding movement between bone and mucosa is considered. Therefore, this poor assumption can lead to a significant error when a large amount of the bone movement is involved. Previous studies showed a relatively large amount of error in critical regions, despite the acceptable amount of overall error. Therefore, the accuracy in those critical regions need to be improved and separately evaluated. In this study, we hypothesized that a more realistic sliding effect is a key factor to improve the prediction accuracy in critical regions. We developed a two-stage FEM soft tissue simulation approach, including introduction of nodal spatial constraint to improve the accuracy in critical regions. I would like to explain briefly about our algorithm first. We need to first prepare patient-specific mesh model of preoperative phase. And then we apply tissue property and boundary condition on this mesh. And then two-stage simulation is implemented. Then we predicted the facial soft tissue change after bone movement. Because of the generating patient-specific mesh model, it takes the days of work. For the purpose of clinical application, we used our previously developed method that generate patient-specific mesh model from template data. It saved a lot of time and efforts. For computational efficiency, we used the homogeneous linear elastic material model for our study. We found that the soft tissue property change was negligible for our model. Therefore, we used these values. We used these values as a tissue property from the test result. The FEM simulation was implemented in two-stage manner. In the first stage, we applied the bone movement together with the sliding effect with nodal force constraint. In the second stage, we improved the result of the first stage by applying sliding effect with nodal spatial constraint. The boundary condition was assigned on the inner surface of the mesh. However, it is illustrated on the corresponding bone surface for better understanding. Nodes can be divided into two big groups, boundary nodes and pre-nodes. Boundary nodes are where specific boundary condition is assigned. On the contrary, no specific boundary condition is assigned for pre-nodes. Boundary nodes can be further divided into four subgroups. Fixed nodes are considered to be fixed during simulation. Moving nodes are nodes that move together with the bone. Sliding nodes was selected around the mouth to simulate the sliding movement of the mucosa. Scar tissue was assigned to simulate the scar formation after surgery. The last of the nodes were assigned as the pre-nodes. The movement of the pre-nodes was determined by the movement of the boundary condition after solving FEM. I will explain more about the post-operative bone movement. Pre- and post-operative bone was restored, and the postural osteotomy was performed according to surgical plan. The post-operative bone movement was calculated by restoring preoperative bone to the post-operative bone. This calculated post-operative bone was applied as boundary condition for moving nodes. In the first stage, the sliding effect was applied with nodal force constraint. Only the pores that is tangential to the bone surface was considered to simulate the sliding of the mucosa on the bone. This method was adopted from the previous study. The first stage simulation result was calculated by solving FEM with this given condition. The result of the first stage was quite good when movement of the bone was small. However, when the large amount of the bone movement is involved, the mismatch between inner surface of the mesh and outer surface bone happens. This is clinically not acceptable. And this mismatch is fixed in the second stage by re-establishing the relationship between these two surfaces. New boundary condition was assigned for the second stage. There is no sliding nodes anymore. Instead, the area where the mismatch needs to be fixed is now assigned as a moving nodes. In the second stage, the result of the first stage was further improved by applying strict nodal displacement boundary condition. The nodal displacement of each moving node was calculated by finding the closest point on the bone. This procedure was processed from cranial to caudal direction, like this, from top to the bottom. to prevent undesirable mesh distortion and to ensure the inner surface follows the bone surface well, even for the occlusal area where the upper teeth and lower teeth meet. Two different methods was separately simulated for accuracy evaluation. One is the traditional method without sliding impact, and the other is our two-stage approach. Total of 30 cases were investigated. Evaluation was performed in quantitative and qualitative way. This is the example where the severe amount of the vertical bone movement is involved. You can see in traditional method result, large amount of the vertical error here, but after applying sliding effect, the vertical error was much improved compared to the traditional method. However, there are still errors in transverse plane. In the second stage result, you can see the inner surface matches well with the outer surface bone, and the error in transverse plane also improved. You can see how much error was improved in vertical and transversal direction compared to the traditional method. The error was evaluated for the whole face and 8 sub-regions. The regions were divided using anatomical landmarks. Here is the animation showing the facial soft tissue movement according to the bone movement. In quantitative analysis, displacement error between predicted result and real post-operative phase was calculated. In qualitative analysis, 2 surgeons evaluated the result using a binary visual analog scale. That is acceptable and unacceptable. Here is a table showing the improvements of each stage compared to the traditional method. In quantitative error evaluation, the first stage results show the improvement only in the nose area, whereas our 2-stage results show the improvement for the whole face and the critical region. The malar region showed significant improvements for both results. In qualitative error evaluation, 43% was acceptable for traditional method and 1-stage only result. However, 73% was acceptable for our second stage evaluation, second stage result. The accuracy was improved for the whole face and critical regions. And the result shown here is well reported in our MICCAI paper, and later we found some interesting things. These are the typical class 2 and class 3 cases. That is a clinical term. And here you can see the lower jaw moved backward, and here lower jaw moved forward. And you can see some differences, changes in lip status compared to the pre and post. And the 8 unacceptable cases were due to this initial lip status, and this thing has now been fixed. In summary, the sliding effect effectively improved the accuracy in critical regions, and this result confirmed our hypothesis. But we still need to work on to find a better quantitative error evaluation method to reflect the clinical meaningfulness. This is our post number. Thank you for attention.
Thank you for this very nice presentation. The paper is open for questions.
Hi, very nice talk. I will ask a very quick question. So how do you implement the finite element model? Use software or use the programming language?
We developed their in-house program under MATLAB code.
Use a MATLAB code?
Yeah, right, MATLAB
okay.
code, yeah.
Thank you.
Thank you.
Thank you for this nice presentation. My question is about the values that you took for the Young modulus and Poisson ratio. Is it the same values for the 30 patients? And do you think that it is realistic?
Yes, as I mentioned earlier, that we found that even though the tissue property is an important factor, but we found for our model is a homogeneous linear elastic model. For our model, the changing property, soft tissue property doesn't make any difference. So that's why we used all the same property for the whole patients. Thank you.
One more question.
Thank you for your talk. You said that you used a homogeneous linear model for your finance elements model. How much do you think it will improve your model because in reality, skin and facial tissue are non-linear heterogeneous. How much it might improve your results, you think, if you add this more complex model of soft tissue to your model?
We also perform some preliminary study testing the anisotropic property. Well, we wasn't able to find significant improvements. That's why we choose to use the homogeneous elastic model for efficiency. Thank you.
Okay, so let's thank the speaker again.
So let's thank all the speakers, the very good talks. We have the bars is open for discussion if you want to have some coffee. And then we have the poster session, and I suggest you to come back at 12 for the keynote lecture by Johan Medan. Thank you.